Hello, everybody. Are we on? Yes? Okay. Okay, hello, everybody. Welcome back to the live cases of catheter ablation. I'm Frank Marchlinsky from Philadelphia in the USA, and with me is chairing the session, Dr. Zeppenfeld from Leiden, the Netherlands. Are we able to connect to the live cases?
Hello. Do you see us? Do you hear us?
Yes, very well.
Okay, so hello, welcome. This is lab number 4. My name is Petr Peichl. I'm here with Predrag Stojadinovic, and the plan, what we prepared for you today is to demonstrate a case ablation, epicardial, endocardial ablation of ARVC patient. Let's first introduce the team. That is quite a big team, to be honest, so it's a teamwork. It's me, my colleague, there's 2 technicians, Sarah, Jacob, and anesthesiologist team, and nurses, Radka and Sharka. So I have to acknowledge all of those people. So let me introduce the patient. The patient is quite young, a 26-year-old male, had quite recent the whole history. At the end of the last year, he had a syncope after ice hockey skating, and he underwent, it was a quite severe syncope with 2 minutes of loss of consciousness with and he had an MRI afterwards, and he was diagnosed with ARVC because he fulfilled major criteria with dysfunction of the RV, with also structure dyskinesia of the free wall. But actually, the MRI looked like more like biventricle involvement might be possible because there was LV subendocardial LG in posterolateral LV region, which is sometimes the case. And he also underwent the genetic testing, which came up with plakophilin mutation. But the story here is quite is a bit kind of complex because the variant of this mutation is so far classified as a class 3, so variant of unknown significance. And generally, the plan for today is somehow contribute to the genetic diagnosis because there is a defect in the DNA of this gene, but to verify that this is really relevant for the structure of the protein, we need to have a RNA, and we can test the RNA that it's also damaged by the defect in the DNA. And the problem here is to get the RNA, normally for most of the genetic diseases, you get the leukocytes, then you derive the DNA, you derive RNA, but this plakophilin protein is not expressed or is not expressed outside the heart. So if you take leukocytes, you get only DNA. So the point of today was also to perform biopsy, to get few samples, not for the structure histology, but to have a RNA from the heart, because there where the gene is expressed, and somehow contribute and verify that this is a gene that actually causes the disease, which probably from the phenotype we'll see is the case. The patient underwent implantation of subcutaneous ICD and is on therapy of beta blockers. Can we go for the next slide? This shows you baseline ECG with a typical pattern of teen negativity, V1, V2, maybe V3. But if we go for the next slide, we'll see this late enhancement, not only on RV, but also with the points or the arrows on the posterolateral LV and the enlargement of the right ventricle. If we move to the next slide, this is why he is here today in the lab in general anesthesia for ablation. He had several series of shocks, and which is not what we would expect, maybe the monomorphic VTs, but it's more kind of repetitive VTs that were coming and going. Obviously, the ICD didn't recognize that very well, or just did the therapy, but there was a repetitive arrhythmia, something which the ICD is not the perfect tool for. Can we go for the next slide? And this is another longer episode. This is probably caused him the syncope in the winter last year, but the ICD therapy, I believe, is not the perfect solution because it will give series of shocks. So this is the kind of situation. We have a patient with a young one who had, despite therapy of beta blockers, this series of shocks, and he has a structure which looks like RRVC. He has also the genetic testing, and we hopefully we did take the biopsy to verify that also the RNA is kind of damaged, and we can contribute, but we had to get the biopsy from the heart. So the plan was, because it's a young patient, for those we go our first approach endo-epi, because that's actually where the disease is in these young patients, at least in our experience, and it's not our only. So before that, we also did CT. Can we move to the next slide, just to have an idea about the interposition of different organs? This is most straightforward kind of. This is kind of either way, posterior, anterior, or inferior anterior approach would work the same. We start to do these CTs regularly for our planned procedures, mainly because we had a patient and I would like to show the next slide. This is not the current patient, this is from the history, but it just shows you how sometimes the anatomy can be difficult. So, and this made me to do the CT for most of those cases, because if you see the heart is enwrapped by lungs, and there's also stomach kind of injury, so the whole heart is somehow hidden inside the chest. So if you have such an anatomy, you know up front you don't risk potential complications that may arise. It's not our case today, but this is just to justify and to demonstrate that the imaging in this year or in the current era is something that is probably easy to do and makes a lot of sense to do. So this is the demonstration of the patient history. Are there any questions regarding the indication? It's a young patient with shocks despite beta blocker therapy, and is scheduled for this endo-epi procedure. Nice. Are there any questions, comments?
Nice job, Peter. Can you hear me? Frank Marchlinsky? Yes?
Yeah. I can hear you, not very loudly, but maybe they will adjust the loudness. Okay, now volume. Okay, perfect.
Okay. I know Katya and I both have some questions, so I'll let her go first. Okay?
Peter, thank you. Thank you very much. Can you hear me clearly? Can you hear me?
Yeah, perfect.
Okay, thank you. I'm just wondering, did you perform an exercise test or something to get a kind of idea? I mean, with the exercise-related non-sustained VT to get the 12-lead morphology, perhaps, or a 12-lead Holter? Of course, I think it's very reasonable with this MRI, but just curiosity if you have any idea how the morphology would look like.
Yeah, that's a very good question. We didn't have. Obviously, it's a possibility to have a 12-lead morphology. We didn't do so. We hope that we can induce it in the lab, and we did. So yes, that's something that might be considered in the kind of planning phase to do.
Peter, I know we're talking about ablation here, but is your routine for these young patients to use a subcutaneous device?
Yeah, we try to follow in these young patients this strategy of combine subcutaneous ICD and ablation, just having the monomorphic VTs being able to ablate, and the very rapid ones, those ones that are maybe malignant, be treated by subcutaneous ICD. Otherwise, it must be noted that the conventional ICD with a single chamber ICD is probably preferable, because most of these arrhythmias can be terminated by the ATPs from the lead. So I believe this is something to discuss. In this particular case, the decision was made because of the young age of the patient to go with the subcutaneous ICD because of the suspected or anticipated lead problems for the future, and the plan was to go also for this endo-epi once he starts to have episodes that will require this. This is approach that maybe we will try to do in following years. Whether this is the good strategy, I leave to the discussion, but this is what we decided to do.
I think since many people in the room do the same, I think it's a good, maybe we combine our efforts to look at the effectiveness of that strategy, because I agree with you. Can I ask you, you're going to epicardial approach, which is fine, but is there a subgroup of patients where you do an endocardial approach prior to the epicardial access and approach? So for example, when we see an aneurysm, on imaging, aneurysmal formation around the infundibulum or around the base of the bottom of the tricuspid valve, we will frequently go and approach this endocardially first and get rid of whatever VT we can induce. And typically, if they're still inducible, then go epicardial, and many of them are. But what are your considerations?
Yes,
are there
yeah, I
anybody that
completely agree that
you
not-
would step back and say endocardial is preferred? Endo
Generally,
first.
I don't know.
I don't mean endo only. I mean endo before you do the epi.
Yeah. Completely understand. Generally, the frailty of the patient is one aspect that still the epi is might be a risky procedure. So this is something to consider and discuss with the patient of the risk of the epicardial access. And generally, the young ones, we believe you should go epi straight as a first line therapy, because the young ones do have a very nice substrate epicardial, and you have to go there. For the kind of, I know it's maybe our kind of, not everybody accepts that, but if you are 50 years of age, there's a very nice substrate endocardial, you can very nicely treat that and be quite effective with this one. But for those 20 years old of age, I believe the epi upfront is a very good idea to go first.
Thank you, Peter. One more question.
Okay, so
What do you do with the imaging information where everything's gets in the way? What do you then, or what's your strategy?
yeah, that maybe ask a surgeon to help. Obviously you try to find out the optimal way. This is, I believe, horrific case, and because if you really look at this, there's a really very tiny window. We were able to get to the epi in this particular case, but obviously we hit the lung. And if we knew, we would somehow to address it, maybe with the surgeon using the window or some other approach. Generally, it's nice. At least I like it very much to know whether I should go anterior approach or inferior approach. I believe both can be helpful, especially in this. If you have the whole heart wrapped around with the lungs, you better not do pneumothorax or hemothorax with your needle. So I'm just saying it's if this imaging technique or CT is very available, and sometimes you may at least to know what to expect, not just to run up front and stick the needle inside.
Very nice.
So if I can move on, I would like to show you the echo. Can we switch to echo screen? As I said, just this is the biopsy that we did in the beginning. It is you see the bioptome. This is just to show with the echo you have everything under control. So this is opening of the bioptome. Can we go for the next this one? And this is, you will see that we capture a bit of the septum. So we did the biopsy from the septum. You see that the small tethering movement of the septum when we grab a small piece of the tissue. So now I will just move to the X-ray. Can we switch to the X-ray? Then maybe if we can run the loop with the epicardial puncture. So just to, if you can run it, this is, I still use this LAO projection for I don't use the left lateral, that's my way. I don't know whether this is transferable to others, but what I do and what my trick is, when we inject a little bit of contrast, then I load it with wire, and once I get into the kind of I feel that I pass into the pericardial, I go immediately with the wire in. So when I pass, can we go back? I just want to comment on this. So if you watch this, and at one point in time I pass into the pericardial space, or I pass something beyond the contrast, it's not now, but just now, and I immediately go with the wire. So generally, because it happened to me when I was there and I had an injection of the dye and then I switched for the wire, I sometimes lost it. So this is just when I get there, I immediately go there. And if you go for the next image, this is the wire in the pericardial space wrapped out. Or you always want to be sure that this is correct. And we had no blood in the first aspiration. So now we will.
Just Peter, I want to comment because everybody should appreciate it. Preloading the wire when you get in close proximity, and then directly advancing the wire without that exchange is a very helpful tip.
Okay, so now we will move to the CARTO. Okay, now with the PRUCA review screen. So can we switch to the PRUCA review screen and go for the first? We induced 2 VT morphologies. This was the first one. This is something you would expect in the IRVC. So left bundle, positive 2,3 AVF. And there was another one, so can we switch to another one? This is from the inferior wall. Again, V1 is a QS, so it's also something coming from the right ventricle. So everything matches that this patient does have a ARVC, and that's not only variant of unknown significance. So now we will switch to CARTO. So can we switch to CARTO?
Can I ask you one question? This was induced without isoprel, just by program stimulation, and you think this is re-entry tachycardias, right?
These were sustained and these were re-entrant. Yes. Obviously, on the subcutaneous ICD, this was more repetitive. But generally, I believe these still originates from the pathologic areas, that if you treat them, you get rid of those repetitive arrhythmias. But these were re-entries that were sustained, and then we had to shock the patient once, and the other one we were able to do with anti-tachycardia pacing. So maybe we can switch to CARTO. Oh, CARTO, please. Okay, so this is the epi map. So this is bipolar voltage map, 0.5, 1.0, 1.5. What do you expect? There is this low voltage red zone, which doesn't mean, in my view, always the scar. It may mean also the fat, epicardial fat, but what you look there, and we always, when we use decapolar catheter, decanaf for creation of this, because I'm very happy with this catheter. We always look at the signal quality, not only on the voltage, and when we did on this, we tried to scan also the lateral wall of the left ventricle when we looked for some epicardial involvement for this, and we generally didn't find that much interesting. There was no real juicy signals, what somebody called them. And the real ones, the interesting ones on the RV, so these were the black dots, and I'm there with the decapolar catheter, and maybe we can show you the real-time, or maybe the Pruka late potentials, which will be the number 3. So can we switch to Pruka review screen? Okay, so I believe this is a very nice demonstration of the disease, what you expect in a young patient with ARVC. We looked for the exits of the inducible VT and generally found one for the upper one was just above this scar, which was I don't know where's the violet color visible on CARTO. Can we switch to CARTO? This is this is the pacing and can we switch to CARTO? So this was somewhere close to what the most pathology was the exit of the resembling the VT morphology. And then there was the other one which was down close to the annulus. If we can we shift the map up, and was somewhere on the close to the inferior wall, somewhere between in that area. So this somehow coincides with the involvement of this, and we were able to also see because the patient was not tolerating these arrhythmias were very rapid. We had a possibility to record some mid-diastolic potentials. And can we go review screen? These were mid-diastolic potentials during the VT2 at close to the inferolateral tricuspid annulus. Then we generally did the coronary angiography just to know what can we switch on X-ray to do the angiography of the right coronary artery? So generally, this is my images, so it's not perfect. Sorry, and I was never trained to really do that. So this shows you the decapolar catheter on the most interesting part, and there are 2 branches of the right coronary artery. Generally, the bigger one goes below that, so we mark that on the CARTO map not to damage them. Can we go to the loop number 7 or number 9, which will show you the right coronary artery, the lower part? Můžeme přepnout. Okay, so this one, and look for this inferolateral aspect, and there was generally nothing interesting epicardially that we should be afraid of. It's not a perfect shoot of the artery. Again, sorry for this. It's my job.
So Peter, can I ask you, your standard approach then is to do coronary angiography, and you will avoid that mid free wall coronary, and you'll tag it and avoid that branch?
Yeah, generally if it's really tiny, we have to think whether we should sacrifice those. Initially, we try to avoid those, and if it's really on the top and if it's tiny vessel, we go with a kind of lower power setting over it, because generally we have to treat the patient. But initially, no, we try to avoid those if they are there.
Sure.
But depending on how the situation evolves.
Peter, can I ask you one more question? You have looks like you have an ICE catheter there, isn't that right? Yes?
So, sorry?
You have an ICE catheter, yes?
Yes.
Okay, so I want to ask you, if when you have a chance, and not right now, because I don't want to interrupt your flow and your presentation, but I just wanted to, if you can image, it's a challenge sometimes, but right around that tricuspid valve, and in those two areas where you defined the circuitry, is there aneurysmal dilatation right adjacent to the valve structures? Okay.
Generally, I can show you the ICE image if you wish. Generally, it is in the inferolateral aspect. I will show you later on, but first I will show you the CARTO map of the endocardium.
Okay.
So maybe if we switch to the CARTO, or if this, okay, this is the loop image. So maybe if we switch to CARTO and we do the endo map. So this is bipolar map, so can we just rotate it? And you generally see this is typical kind of finding in these patients with ARVC, with the basal posterolateral peritricuspid scarring, or this is bipolar WAP, this is real scar. And the question is whether is something visible on the unipolar map, because our free wall involvement was definitely there, as you saw the late activations there, and you see with the unipolar setting of 2.5 and 5.5, or generally we play with these scales to see whether any region is kind of also appearing, and I believe the free wall is also affected, which is shown. Can we show the free wall on the CARTO more, maybe this one, yeah, in this direction. So yeah, there is some disease, and the violet color there is the exit site for the VT1. So maybe now we can switch to ICE. Můžeme přepnout na echo, and the visibility, hopefully I'll show you that there is some aneurysm on the inferior wall that is, or there is kind of the recessus of this aneurysm. Maybe this is visible now. I do apologize for the imaging quality, but maybe now if you see this, there's this kind of opening between just below the tricuspid, this kind of fissure, or I don't know how to call it, or pseudo-aneurysm. So this is something, the ICE is very helpful to locate these structures or these cavities, caves maybe, that you want to go there, and maybe on echo. Do we have these recordings that we showed? Also, the catheter was in there because we were mapping this aneurysm. So yes, the echo is helpful to really explore these different aspects. Or endocardially underneath the valve to really be that you're sure that you visited those. So maybe this is loop when we had with the catheter on the annulus. So the echo can be helpful to really verify that you're really touching, that you're really on the tricuspid annulus. Obviously there you can watch the signals, but this is more kind of easier to. Co to děláme? Okay. So generally, because this is what we have. So we have these two areas, definitely scar endo, and definitely epicardially very attractive sites. If we move now to the real-time PRUCA, can we move to real-time PRUCA? Okay, so we have this decanav on the lateral free wall of the right ventricle. You see these electrograms there, and that would be definitely one area to address with RF delivery. The other one we already started to do, which was endocardially this posterolateral aneurysm. Can we switch to the CARTO map back again? Sorry for this, but it's kind of. Can we switch to the CARTO map now? Okay, so we already started to ablate in this posterolateral, so there are already lesions deployed there to somehow homogenize and try to interrupt areas there. So the plan so far for me is to do endo here, definitely underneath the valve, and be sure that you cover all these aneurysms or this aneurysm that is there, and to go epi to wipe out those late potentials that you saw on the free wall. Which there is endocardial is not definitely visible; they are not visible, but epi there are very nice there. So.
Yeah,
This is the plan. Endo something was done, then we moved to epi, and we tried to do this epi, try to eliminate these pathologic late potentials, actually, and then try to see whether there's something inducible and extend the ablation depending, and maybe remap to be sure that we wipe out all these abnormal activities there. Any comments to this?
Just one short question. What did you exactly target on the endocardium? Did you also have this delayed potentials there, or was it just based on the low voltage area?
Yeah, I forgot to show you so can we switch to Pruka? Yeah, the flow is interrupted. So we've prepared this. No, it's a very good question. So can we go? Yeah, this is the signal because I'm not using for the endocardial mapping multiple or multi-electrode catheters. So this is just the ablation, and I hope you can appreciate this late potential underneath the valve. This is atrial component, this is ventricle component delayed, and this is this late potential. So these were the signals that we targeted with endocardial access. This is the endocardial underneath the tricuspid valve signal.
May I, the last question, What are the voltage settings now on your Bruker system? Because it's very tiny, but the local electrogram, the first ventricular...
Can we enlarge the ablation catheter, the review screen? Can we enlarge the signals there? Ablation, zvětšit review. Gain. Okay, so this is, I don't know, kolik to je? How much is it? This is 5,000. Okay, so it was probably low. Okay, sorry for this.
No
but
problem.
I believe this is now very kind of apparent, these late potentials underneath the tricuspid.
Thank you.
Any comments?
Any other comments from the audience? Anybody in the audience? I think you're doing a great job. This is very clear and very nice.
Okay, so now I will just go because I will remove the decanav from the epicardium, and I will go with the ablation catheter and try to eliminate all those electrograms that we annotated, and generally not here to ablate all the red because it's too big, but I mean all these delayed activities, and maybe extend it a little bit lower and we try to see whether it's still inducible, and then we will see whether we have to extend the either endocardial or epicardial. Hopefully, looking at the electrograms during induction of both epicardial, endocardial, having catheters on both sides, seeing what's earlier, and trying to address the site, not to do too much, but just to do, I would say, proper amount of the. Can we move to the maybe CARTO map on the Pruka screen? Or on the big screen, sorry.
Peter, one quick question.
Sometime.
You're not double wiring and putting in two sheaths and using the decanav to guide your ablation catheter. You're using the electrogram recordings that you have and the tagging process to...
Yeah,
okay.
Generally we remap. So we put there the catheter and then we reinsert the catheter again and again. Yeah, the double wire is another option just to online see what you're doing. Well, yeah. If you have a clean puncture, that's probably very doable to maybe considered. So maybe the black ones were the real ones. They are not that apparent in the, I must admit, in the single tip catheter as was in the decanav, but these were really the ones that we target. Maybe if we go for the online screen of Pruka, we will see that there is something maybe, but it's not that apparent. That, yeah. But the multipolar in the epicardium is definitely advisable because this really can help you to. Can we increase the gain?
Actually, they are.
Yeah, they are there. But it can be probably easier overlooked if you don't have that. It's much more difficult to overlook them in the decanav rather than in the ablation catheter. So we'll start with 30 watts, and we start to do a draw line from up, from down to up, and maybe extends to somehow more to the apex, because there we see some repetitive activity during these induction attempts.
Peter, we're
So
going to
that's
ask
the
you
plan.
just to show us on the electroanatomic map where your lesions are planned. So are you, and at what area? Are you going to use the electrograms only, or do you going to target a region of
Can we switch to
electrogram
CARTO?
abnormalities? Because again, you pointed out sometimes the
Okay.
electrogram abnormality will disappear.
Okay, so generally the black dots we should cover. We should extend it up to the violet color tag. I don't know whether that's very, okay, maybe he highlighted that. So from there, just going across this region, and we saw some interesting potentials also where the green dots are. So generally this will be electrogram guided. I don't know, obviously there's a big red scar or big red area on the posterolateral. Initially, we did something from endo. We may also consolidate that from the epi. There are some black dots there, so just not that extensive ablation might be done there, and then we'll see with induction what's left. That's my actually plan for to do.
Do you anything like pacing for capture, in particular if you're towards the tricuspid annulus or in the deep red scar areas, to see if this is capturing at all, or if this may be also fat layer? Are you using pacing or pacing thresholds at all in your study?
Yeah. Generally, that's very good kind of remark. Not all the red in the epi means that you should burn it or it's the scar. It can be and you should only ablate at those sites that do have a capture. So that's why I'm actually planning to ablate on the border of the red scar, not just to cover the red zone. And yeah, we had a problem with capture in the lateral. That's why I think it's more fat. So yes, that's very good kind of comment. Okay,
Go ahead.
so I will start here with the 30 watts. I'm not that aggressive in the epi, and we go 20 to 25 seconds. Can we start here? And I don't move the catheter, I just do point-by-point lesions. But there are many ways to do it, so depending on your strategy, on your people use high power and just move the catheter.
Are you doing anything to judge
obviously
contact, and are you monitoring impedance as you ablate? What's your strategy?
Generally, we look at the impedance, obviously not too much impedance rise. We want to have just this 10 to 15 impedance drop, and it's already there. It's usually good lesions, so we don't really go above that. So yeah, that's. I look at the impedance, and I just deliver this. In the epi, if you don't have any fluid, you should have a good contact anyway. So if you suck all the fluid, so generally I don't use that much contact force here, to be honest. Can we ablate here?
Do you have a system for draining the fluid, or do you periodically?
No, I
drain
have
it?
my colleague that does it now. So yeah, that can help if you save on one hand. But because of this, I have a help hand from my colleague. Helping hand. Okay. I'll move up. If lets me. Okay, go here.
I apologize for
So
this.
in the audience, can we make a voting how many of those that are attending are doing this first endo-epi approach for these young patients with ARVC, if there is a good indication to do so?
I think most people will do endo-epi. The question is whether what order and how they approach it. But I think that make sure they're not inducible at the end. But I don't want to speak for the audience. I guess I have.
Sorry for interrupting you, but are we supposed to switch to the other lab also while you are now doing, I mean, it's a very clear substrate approach, or is Josef coming after you?
Yeah. So maybe it's a good time to switch to the other second. Introduce. I already consumed 40 minutes of the time, so maybe the other ones can also have a share. Can we ablate here?
Peter, you've been very clear, though. It's very helpful. You've got it outlined the strategy for ablation. So it's 20 to 30 second lesions and 30 watts monitoring the impedance.
Generally, yeah, we had some pericarditis after if you go more aggressive. So generally, it's not usually these are superficial layers stop that can be addressed, and usually not that much. You can see immediately when you start to ablate that these signals are changing. So you don't really, for this disease especially, you may not epicardially be that aggressive. At least that's my experience. Ablation here. Okay, can we switch to another lab? Maybe they are ready.
Thank you very much, Peter. We come
Thank you. We'll be back.
And it's not finished yet.
Are you switching to another lab?
It's up to ICAM, but they will switch it.
Okay.
We are still online, Peter. Be careful. Oh, there's the other lab.
Okay, we've switched to another lab with Dr. Kautzner. Joseph?
Už teďka?
Joseph, can you hear us?
Aha, tak děkujeme, že nás poslali. Tak nám tam dejte tohle.
Can we hear you?
Yes, can you hear us now, Joseph?
And we are already on? Is there any communication?
Yeah,
we can hear you. Yes.
Ah, okay.
Okay, so we are a bit struggling here. This is interesting patient. Let's start from the beginning, okay? This is a patient after a myocardial infarction many years ago, and she... Můžeme to nechat tam chvíli? Zpátky.
Líčka, zpátky.
Můžeme dát ten první slide? Okay. So this is patient who had already ablation years ago, and we did modification at that time of apical aneurysm using Rhythmia. We don't have map, unfortunately, from that time, but we have some ICE image, and the patient is now enlisted for reablation, because after I think 6 years or 7 years, she has now recurrent VT episodes and therapies from ICD.
Excellent.
So we are here with a team including anesthesiologists, as you can see here, and people from Medtronic, because we will use also the Diamond Temp system for ablation. And obviously, to display the catheter, we have to use some other system.
Next slide, please.
Like Ensite X. Okay, now this is what I mentioned already. The lady had anterior infarction in 2004. She had a low ejection fraction, ICD implanted, and the next slide shows that we did already ablation. And that was 6 years ago, and she has no VT recurrences, and now she has again recurrences. So we don't have ECG obviously from these recurrences, because it's all from device. We introduced a transeptal and retrograde approach, and we selected HD grid to map the ventricle. And at the beginning we started with induction, and we were able to induce relatively fast VT, which we can show you now. With exit, which is more lateral and more going up, and it's not entirely in the apical part of the aneurysm. You see it on the right side now, yeah, and this is in a sort of mid ventricular portion is the exit, and because We did already very thorough ablation in apical part of the aneurysm and apical septal. If you can move a little bit the map, you can see that up, a little bit up. You see that this is area where we did the last time, and there are no late potentials at all. And there are some fragmented signals, and with a very large delay, these dots down there, they have quite large delay, but this is more like lower apical exit from that pacing site. But then if we can move the map down a little bit, we did some kind of pace mapping, and you see these green points upwards, and in these green points we have similarity to our arrhythmia exit site. And if you look at these green points, I don't know if you can see it, the map.
No.
The green one, which is on the lateral part, the green ball, is a true exit. And if we go more septal, if we rotate to the right, these two guys, which are in this lower voltage area, there is a very similar morphology, but a longer delay. So our idea is that the critical isthmus for this arrhythmia is in the area which is marked by a white line. And if we go to that area, you have lovely fragmented signals. And if you pace from that upper part, you still have the morphology of clinical tachycardia. If we pace from the lower part, where you have these blue dots, the light blue dots, you have completely opposite morphology, which was also on one occasion we had during program stimulation, we could induce rounds of tachycardia with a completely opposite axis from the similar area. But we terminated that arrhythmia during mapping because you see these lovely signals.
Pruka, please.
Can we show Pruka now? So this is tachycardia we induced as a second tachycardia, and you see all diastolic potentials across from the early diastole to systole practically. And this is from the area of that white circle on Ensite. And this tachycardia terminated when we were slightly moving the catheter within this area without ectopic beat, you see? You see?
Yeah.
So there was no ectopy and it terminated. So we believe that for these two clinical tachycardias, probably clinical because the cycle length is very similar, what we recorded from ICD, that we have to modify this area which is really on the margin of the scar. Can I see the picture there? We have to modify this area because it seems to be shared isthmus for both tachycardia, something what Frank showed us nicely in his presentation. So one exit goes up and the other goes down. And the critical part is in this area which is linked with or marked with a white circle. And then we probably will do some more because in that red spot there is another quite long delay, but it goes towards the apex, and there is a delay like 150 milliseconds when you pace from there. But when we paced the right ventricle with extra stimuli, we could not see a significant, I would say, delay of potentials like functional delay. But I think this area was heavily ablated in the past, so there might be still some epicardial, maybe or intramural part which it could be conducting. So the plan is actually to modify. Start with this circle area, do ablation there, and see if we can achieve complete modification of this area, and then we will continue towards the apex along these points which are marked, just to get rid of this low, let's say, the slow conduction within this area. So this is our plan. On a lateral wall there is nothing important, and we did not map thoroughly the perimitral area because we felt that there is no need for that. And so this is our plan, and this is our state of, let's say,
Joseph, I want to ask you a question.
Current status.
Beautiful recordings, beautiful example of the continuous activity during ventricular tachycardia. But can you do us a favor and alter the color range and just take the slider bar and move it up? Is this truly just an extensive patchy scar, or with the multipolar catheter, are you sometimes picking up bigger amplitude signals?
This is very good remark, because I'm not that much used to this multipolar, and let's say I am used to it, but I'm not used to amplitude of the signals. And
Right.
if this would be mapped on point by point, for instance, with CARTO, there will be the whole area will be very low voltage, because it takes also some far field signals, and it with this low spacing or small spacing, it probably overestimates the voltage. So yeah, you can play with voltage, but I think here I was more guided by signals and by
Sure.
this fragmentation. And I also use during any procedure, I use a lot pacing from the side, whether it's ablation catheter or other mapping catheter. And I look at both at morphology of paced beats and also on delay. And if you can trace from exit to the central zone with prolonging delay and similar morphology, so you know that you are in the channel. Then you have this watershed, so this is like watershed, and then it goes down from the lower part of the circle. So I think we have lovely isthmus which can host 2 tachycardias, and we will do modification here, and then we continue to that apical septum, where you have this very low voltage and very long delay, but it's a very apical exit. All leads from V1 to V6 are negative.
Yeah, I think the only point I was trying to emphasize, which you've already indicated, is that just because you see purple, it's not normal tissue. And certainly, again, the 1.5 millivolt cutoff and how that was determined statistically, and how nicely you can see with patchy scar abnormality going up to 2.53 millivolts, and especially if you use different catheters. So I think in this case, when you move it up to 2.5, it begins to be more like what you find when you're mapping, with this single.
This was nicely demonstrated by Katja. They showed nicely that unless you have really transmural scar, this 1.5 may not be applicable. And often I see from different centers, they say there was no scar, and they look only on color.
Right.
And if you look at the signals, you see that there is tremendously large potential, let's say fragmented potential area with delays, and there is a substrate which is visible also on intracardiac echo, but it's not transmural, and you have a lot of musculature above, and then it creates this high amplitude potential. So this is very true that violet color is not healthy myocardium necessarily.
And it will be exaggerated by small multipolar recordings, because again, if they're not in contact and it picks up a farther field signal that's bigger amplitude, it's going to tag it as a healthy tissue, and that gets more complicated. So again, it's
so
the limits of what we're doing.
We will use this Diamond Temp. I don't know if everybody is familiar with the technology. It's a technology which has a special design of the catheter, was developed by Epix company. We somehow cooperated on development of this, and we did some studies in atrial fibrillation mainly, and now we finished also some feasibility study in VT ablation, which is called TrackVT, and we are analyzing now the results. And the beauty of this technology is that we have multiple sensors in the tip, and they have very high sampling rate, and there is also diamond cooling that avoids overheating of the tip. So even though it's a irrigated tip technology, it can still measure temperature very precisely, and it can be used in a temperature controlled mode. And this is the main advantage. So, and you don't have any contact force sensing, but if you have bad contact, you see that the temperature does not go up. And if you improve the contact, you see the temperature goes up and the power can go down because it regulates automatically. So it's very convenient for you that you basically work in the temperature guided regime. And especially for ventricle, you can deliver 50 watts without practically without risk of pop, because we did quite many patients with this technology, and we never seen real dangerous pop because it regulates the power automatically depending on temperature. So that's the advantage of that technology. So any questions?
I have one practical question, because this basal anterior part of the LV, in particular in dilated LVs, is very difficult to reach with good contact. So what is your trick to get good contact in this area?
We go both from transeptal and retrograde, so depending on which area you attack, and depending on individual, let's say, depends also on position of the heart and the relationship of the left ventricle to aorta. Sometimes it's easy from retrograde, sometimes it's much easier from transeptal. So for these cases, we always choose both approaches, transeptal and retrograde, so to be able to toggle between depending on maneuverability and depending on location of the substrate. I think maybe in this area we may start transeptal, because I'm afraid that with this catheter, which is not particularly flexible, I may have a problem to keep in this area with good contact. But I will leave HD grid in this area, so we can see. Sometimes you see a complete abolition of the signals if you isolate that area. So it can give us also some guidance, but I will try now to go transeptal with ablation catheter, and retrograde keep the HD grid. Okay?
Very good, thank you.
We have still, I mean, how much time we have? We have still the recording from Philippe Maury from Toulouse. It is about 15-minute recording on use of Rhythmia for mapping and for mapping during VT. So it depends. We may start ablate and we can come back, or if you want to have now a video, or we can start and then you take a video. It's up to you. Tell me what you prefer.
I think it would be nice to see just the beginning of how you maneuver the catheter, and then we can either switch the other lab for a second to Peter to ask him how far he is, and then we can have the case in the box.
Okay, did you hear the plan? Yes. No,
so we
let's
have.
see here. Yeah.
Can we go to RAO? We have a different sheath today, which I selected because it's softer than Agilis and does not push me too much into the area of. It's softer, but sometimes it does not support as I would like to. But let's try. No. So here we are. Going well, can I see my ablation catheter?
Ensite.
I'm getting to the area of fragmentation, as you can see. Can we pace now from the ablation catheter with 5?
5, yeah.
With amplitude 5. So it goes up, you see, and it's a longer delay here again. So this is a sort of watershed. If I move a little bit lower, there might be already opposite axis. So I think that's good for start. And we can preset 55 degrees, or maybe 55. It will be fine. 50 watts power, okay. So we can watch signal abatement, and you can also show them the screen from the system. We usually continue ablation. We continue. I don't say in the same time. We usually continue unless there is a significant drop of impedance, more like 12, 15. That's quite large drop, but otherwise we will continue see signals, and then we can pace from that area and see if we can lose capture. So can we start?
Yeah.
Good. Okay. So it's distorted during application, the position of the catheter, obviously, a little bit, but that's not the system itself, it's mapping system.
The electrogram on the Pruka is a little bit wavy, but I don't know if it's better on the mapping system.
Yeah, it's... I probably lost a little bit the position because now we are again in contact. Can you make some adjustment that the ablation signal is better visible? So put those higher, yeah. I think it stays now. Can we do respiration, because it's moving without any reason? I don't move the catheter and we fall down with this HD grid a little bit. Can we ablate? Yes. So we reached the temperature 53 degrees. Very, and we keep power 50. Drop is about 8%. There is some small movement of the catheter, so it's sometimes this is again the area where we have this fragmented signal. Maybe some late potential already visible on intracardiac signal. Let's do here. So we are reaching 45 degrees. Impedance drop about 8. I try to get good contact. Maybe we will change then for other approach, but I think it's reasonable. -10 is impedance drop.
I think you have electrogram and attenuation.
Yeah, it's
Yes,
yeah.
yes. That's. I cannot see all things immediately because I'm also checking this screen, but my colleague is watching it. So can we pace from there? So this is a small problem that sometimes it moves. because this catheter does not have sensor. So you have some movement of the catheter.
Koľko je tohle? Co pejsuješ? 10.
I will try to come back again.
We will move to the other lab if you agree, and then we come back to you later.
Yeah, sure.
Good.
So
I
and
have
your
some difficulty to.
Joseph, your strategy now is to ablate around that area where you define the circuitry for the
Yes.
VT with the multipolar catheter. Yes?
To destroy the whole area,
Yep.
to modify the whole area, because this is critical definitely for both VTs which we induced. And then we will continue to the apex and modify also the apical part. But the critical part for these clinical VTs is the margin of the scar, as you can see here. Okay, well, if you come back, then
We'll
we
come
will
back in a bit.
hopefully ablate
Yep.
part.
And so we'll go to Peter's laboratory and see how the progress is.
So I told them to change us to
Okay. Joseph, you're still live. We're still waiting for them to transfer us to Peter's lab.
I'm still alive.
Jsme měli takový ty reziduální, ty jsme si neoznačili, jo. Dobře, tak...
This is Peter. Yeah.
Okay.
Okay. Hello, do you hear us again?
Yes, we can, Peter.
Okay, so generally what we did, we tried to... If you go CARTO, please, switch to CARTO. Okay, so the red dots, maybe if you enlarge it, it's visible that I more or less follow this line that we draw. And we actually eliminate those electrograms quite easily. If we go for a review screen now, what I would like to show that these electrograms go away very, very fast. Can we go review screen Pruka, please? Can we switch, prosím, pro režii změnit na review screen Pruka? Ano, tak já nevím, že to děláte. So what you see here is that before the ablation, there's this late potential. Maybe if we go for more to the left, a little bit left is the other hand. And you see that there is definitely repetitively there. And if you start to ablate, so this is start of ablation. This is the artifact. This is the annotation. If you go to the right, it's there. And after 2-3 seconds, for the next one, it's maybe delayed. And if you go for the next one, more, it's not there. So these usually in the epicardial space go very easily within, I don't know, 3-4 seconds. So generally not that much is necessary. Can we switch back to the cardio? We did this line, we put back the deca nav, and just to verify that most of those electrograms, or not most, but all of them, are gone. We found something more to the septum, so we now extending the line a little bit more to the LV, because we still found some nice fragmented potentials that we somehow didn't see or missed from the beginning. And we also tried to induce, and we didn't have anything sustained, but we have some short runs of generally from the inferior wall. So those we have to address more. So I believe we haven't seen anything from this upper part, so I believe this may be probably done. But we probably have to focus more on the inferior wall. It's not sustained, but several series of complexes. We also, as Katja nicely indicated, went to the lateral part, inferolateral epicardial space. So if you can tilt the map a little bit to the right and up. So if you, I don't know whether it's clear, but there are these gray points. And generally we try to pace all these parts in. If there was no capture, it was gray, it's just car. Generally it means, as Katja nicely pointed out, that this is probably fat, and it makes not much sense to ablate in this if they have no capture. We had few captures in this, so then we try to ablate, but generally this is epicardial fat. It's probably not worth spending the time, and it's probably useless to make ablation in this region, because there's no capture up front, and there will be no afterwards.
Peter,
so this is it. Yeah.
2 quick questions. One, do you think it's fat, or do you think you've just eliminated surviving myocardium through and through with the endocardial ablation?
That's a good comment, but I believe it's fat because it's typical location, even
Okay.
in patients with non-ARVC, that in this Margot you have this kind of more or less sizable sized scar or fat. So generally I believe it's fat, but as you mentioned, I already did endocardial ablation, which I might have eliminated a lot of things there. So that's a very good comment. I didn't, but I believe that this location is notoriously known to have also some fatty tissue also incorporated.
And one more thing, anteriorly, as you begin to come across that anterior free wall, of course you get closer and closer to the LAD. When do you inject dye into the coronary? You have a marker for...
Generally, what you can do, if we go to somehow decrease the transparency of the epicardial map, so can we decrease that and just show the endo inside? I believe now it's clear that the LAD should go much to the left, please. To the other way. Okay, so generally the LAD should, you have the idea, at least a rough idea where the LAD should be. So generally when you come closer to that, you should shoot it. But for ARVC, that's nearly never necessary to do because you're far away. But this endo map can give you quite kind of good estimate how far you can dare to go before you become in the danger zone.
That's a beautiful illustration of that, Peter. Thank you.
Okay, so what I would like to do now is to put decanav into the epicardial space, but to the inferior wall, and try to locate where these non-sustained, still inducible ectopic runs are, and try to maybe do something there, at least maybe to locate when the endo-epi what's better. So I will remove the ablation catheter outside, and then I will put the decanav again, and now I will focus on the inferior wall because we don't have now anything from the upper part from the RVOT, but we still do have something from the inferior wall, and maybe that's something to do more there.
Peter, I want to ask you, because you may know, we have a live in the box case. They said it was about 15 minutes. Should we show that now while you're doing this? Okay, and because we're
and then I will brief you what
and we'll try to get back to both of you before we go to lunch.
Yeah.
Perfect.
Okay, that sounds like a reasonable plan.
Okay.
In the meantime, you are still alive, Peter.
Yes.
Thank you.
Hi everybody. So very sad not to be with you in Prague in June, so I hope you will enjoy. And once again, thank you to the organizing committee of the TogetherVT meeting. So Joseph asked me to present you a recorded live case about VT ablation using the Rhythmia system. So I catch this occasion to share some time with you. So I have selected 2 cases of VT ablation with the Rhythmia system and with all the tricks we commonly used for dealing with such a system. So I hope you will enjoy it. It is a 67 years old male with a coronary artery disease and a remote inferior myocardial infarction with a preserved left ventricular ejection fraction. So during treadmill, sustained VT occurred, which was inducible at EP thereafter, and the patient doesn't want an ICD, and me neither. So unfortunately, there's no imaging for this first case. This is a ECG of the VT, which was inducible. So this is a right bundle branch block VT with the left axis and QS pattern in inferior lead, probably coming from the very basal inferior septal aspect of the LV. The VT could not be induced at the beginning of the procedure despite relatively aggressive protocol using 4 extra stimuli. So we decide to go to substrate mapping, and we use Bigemini pacing in order to build 2 maps with only 1 acquisition. For getting such a regular Bigemini, you have to program your stimulator with a fixed 400 milliseconds delay in the sensed mode and with a pause set to 0 and with the number of S1 also to 0. Of course, there's some specificity in programming the Rhythmia system. In order to do that, you have to choose the template of the paced QRS and memorize it into the system, and then fixed a delta R value for be sure that there was some a good capture, and set the windows of interest around the QRS you want to map. So we begin to map during this full Bigimini beats with the Orion catheter, targeting especially the array of previous inferior mitral infarction, but also collecting data from the whole left LV. This is an accelerated film, of course. The real duration of that was around 20 minutes. So the catheter could be well positioned into this septal basal array. It's not difficult to use it using transeptal or retrograde aortic access, of course. And this is what we get once the mapping is complete. You see rather heterogeneous inferior, very basal inferior septal scar with a relatively healthy left LV elsewhere. Changing the voltage threshold value, of course, reveal maybe some more living array inside the scar. And this is to show you when you're moving the window of the interest from the paced bit to the sinus bit, you have some real changes in the voltage map. Not probably major in this case, but significant change. Now we use the Lumipoint algorithm, which is another windows which is highlighted in the Rhythmia system, and aiming to depict the location of double or fragmented or late potentials on the previous map, which is very useful to highlight the location of this array, which are culprit array or channels array, of course. And using the roving probe, you may see that there was no late potential, no leva, only fragmented signals during the QRS complex. So the analysis of propagation around and inside the scar in this case does not allow us to depict a specific location for petitive channels, for example. So this is the accelerated movie of our ablation in this patient. So we decide to perform a relative complete homogenization of the inferior scar. So using replication, we commonly use half saline in each patient with structural heart disease in our lab, and using 40 to 50 watts. And we deliver around 20 minutes of ablation with the aim of destroying all these fragmented potential, because there was no clear channels and no clear leva, no clear culprit array in this patient with non-inducible VT. And then we perform a new map using simply RV pacing in order to check what we have done with ablation. This process is more quicker, of course. So as a consequence of this dense and methodic earth application, the scar is now completely dense and non-excitable, without any surviving living potential throughout the scar, whatever the pacing or sinus rhythm. And if we can now compare both maps before and after ablation, you may clearly see the difference. Changing the voltage threshold in order to make appear the dense scar, so allow to see the activation with turning around the scar and demonstrating that the mitral isthmus block is complete. And the patient, of course, was not inducible, even using very aggressive protocols and isoprenaline. So the second case is a 55-year-old man with a remote anterior mitral infarction with a very large
apical aneurysm. He was implanted in primary prevention 5 years ago because of the low ejection fraction at 25%. And very recently we recorded in telecardiology a few VT successfully treated by ATP. The patient was under beta blockers at this time, and we decided to propose ablation for avoiding the long-term therapy with amiodarone. So it's a very usual, very classical presentation for this second case. So, and for this second case, we had the chance to use the music software, so coming from Art company, which is a very, very useful tool. These tools allow us to have a very complete and detailed imaging of the anatomy involved in VT, and especially the possibility to delineate the potential channels for VT circuits. This appears in this slide and this short movie, so you can see what's going on with this imaging at these steps. You may design all these structures involved in anatomy and VT ablation. So you may see the aorta, pulmonary artery, coronary artery, which is very important for epicardial access, of course, but also the LA or sometimes fat or calcification inside the myocardial infarction, but also the phrenic nerves and papillary muscle. But the most important things in our case is that you may design the parietal wall thickness in terms of different level of thickness. And we know that the most thin layers of the LV are made of dense fibrosis, while the more thick part are probably made of surviving bundles. So you may design possibly the putative channels of all VT circuit in this patient. And the white dots which are shown here are in fact the design of the RF ablation points the system will propose in order to transect all the potential channels. In fact, it is a part of the in-heart study, which is driven by Frédéric Sacher, collecting all this data in order to prove that we can do this kind of ablation instead of purely EP-based ablation. So we begin first to do a voltage map in order to have a quite good anatomy for merging with the CT imaging. So we perform it using the Orion catheter during a slight simple RV basing in order to accelerate the process, of course. And the important thing is only to have a very good anatomy, and we collect voltage mapping for study also. And then it's time to align, to merge the anatomical map we done with the imaging, the CT imaging. So it can be done using automatical alignment using the system or manually. We use the aorta and sometimes the CS for that. And now it's time for ablation, so we try to follow what the design of ablation line which was proposed by the protocol. Sometimes not so easy, but we do the best for following this design purely on the anatomical map. So ablation was performed using 40 to 50 watts and half saline, and in order to achieve a non-capture at each site. So red points are what we should do, and the green points are the points we really did. So we did not perform new map for checking what we have done, but you may clearly see that there was some exit block from the whole scar after these relatively large lines, despite the fact that we capture clearly inside the scar. And finally, we tried to induce the patient. We did not try to do that at the beginning of the procedure according to the protocol, but at the end of this ablation, the patient was no more inducible.
So I hope you enjoyed this both case. I would just want to show you in which way we were dealing with VT ablation in our lab. So it was my pleasure to present you this both case, and I hope you will enjoy your stay in Prague. So thank you again for inviting me, and thank you, Joseph.
Okay, Peter, we're back.
Stop. Okay. Do you hear me? So generally we try to move on. We went more epi, and we try to induce and see, and nothing is sustained, is inducible. There's no sustained VT. There's just few beats here and there. Can we go to review screen? And this is just few there's triples. Can we go scan those triples? Just what we've had. Yeah. Just for the review. That is one triple. Yeah. Can we? Yeah. Just show different sequences. Just go one above. Yeah. So can we go above that? Yeah. This is triple. So can we go just to show? There's not much inducible. Can we show some other ones? So above that, so before that. So in other words, there's not much inducible. There's still some short runs, few beats. There's not much epi, definitely interesting. We try to have decapolar on the inferior wall to see, but they are very changeable, pleomorphic. They are not really mappable to one single spot. So we will probably just do homogenization of the endo, and then we finish because nothing is really inducible. So can we just scan those for the review screen? These are triples, so this is one of the sequence. Můžeme sáro posouvat o jedno. So this is one of the sequence. Yeah, just go. So this is good. Yeah. So show the, but 12 lead maybe. Yeah. There's a triples. Then we go more above that. Yeah, you see a few beats, but then it terminates. Can we go to the right just to see this one? Yeah. So probably it's time to finish. I wanted to, it's always the best is enemy of good. So maybe we have no inducibility with triple extras, and we went epi. We don't want to leave anything behind in epi. We just not to come there in 6 months. To do some because of the recurrencies. So we want to be sure that the epi is done. There's nothing left, not to go there again, not to be forced to go there again. With endo, that can be repeated. If there is a large endocardial substrate, well, maybe this is something, but generally, obviously, the aim is to have a non-inducibility of any sustained VT, which we had in the beginning, and it's not now. So I believe we had a reasonable outcome.
Peter, when would you use isoproterenol? Do you use it in this situation?
It's not our general practice, but for this disease, it makes some sense to do. Well, obviously, that's how far you dare to go. We generally don't. It's not our general practice. That's my answer. But obviously, you're right that might increase sensitivity of this programmed ventricular stimulation to some degree, but also have some non-clinical stuff inducible with high-dose ISO. So it's not our practice for this. If we feel that we reasonably modify the substrate, epi, and also endo. And usually the results are good. We with this diagnosis, the epi somehow change it dramatically, the outcomes. So I believe that the outcome is usually quite good.
I think the only patients we might consider it are people that don't want a defibrillator and sort of insist on not getting it, and then we'll push it and make sure that they're...
That doesn't happen here. The people usually want the device. So
Thank you very much,
it's
Peter.
Thank you very much,
extremely
Peter.
rare that people would refuse. I don't remember those that much.
Beautiful case, nicely displayed, excellent. Okay, thank you.
Thank you. So let's finish.
We switch to Josef.
Yeah.
Here.
Rozsvítíme, končíme, jo?
Chceš vodič do toho dát?
Nemu-
Yep.
So we modified to great extent that area which we designed on the septum, and I want to change the catheter, let's say, approach from transeptal to retrograde. And before I ask my colleague to do modification of this very apical part, which is down in this red area with very large delay. Maybe we can show this delay which we paced last time before the ablation here. And this is very, very long delay. No, not this one. So we decided to modify this area, and then we will change for a retrograde approach to reach maybe better that area on the septum, because there is difficulty to keep the catheter. Bylo to poslední stimulace, kterou jsme vůbec dělali, jo? Tak nevím. This is it paced? No, show me some pacing from that area. This is stimulation from that area with a long delay. Again, changing morphology, which again shows that there is another kind of watershed going up and up and down. So we decided to connect this area where she's now ablating, if we can show the map, to that red spot which is above to the left. And that will connect basically the whole septal part of the aneurysm. And then we already checked in that white area. We checked with multiple catheter with HD grid, and the fragmentation is much less because it's already modified. The signals are really abated, and then we will finally do program stimulation, obviously, at the end of this procedure. But we have some issues with some movement of the map, maybe, or drift of the map, so we try to keep it pragmatic a little bit, but I believe that we sort of showed how interesting is if you have already one ablation done in this lower part, and the patient has a lot of trabeculations in that apical part, so we modified that a long time ago, and now we are focusing only on that area of this septum. So maybe it's time to change for retrograde. No, you are in the right atrium, in left atrium. Sorry.
Let's see if there are any questions from the audience. Any questions for Josef before we break for lunch? And let him finish. I think it's pretty clear in terms of what was done and what you're going to do. Good luck on finishing that. Will you continue to ablate if you can?
Bon appetit for...
Yeah. In the retrograde fashion, will you continue to ablate in the upper portion too, if it seems like the contact's better?
That's our intention. That's our intention to
Very
try
good.
From retrograde.
Well, terrific.
So, sometimes it's more complex or from standpoint of manipulation, sometimes it's not everything easy. So, but we are, I think, on the right track, and we will inform you later today how it finished.
A beautiful job. Okay, we appreciate it. Thank you.
Thank you, Frank, and have a really enjoy the lunch.
Yes, thank you.
Thank you.
We'll be thinking of you.
Zvětšit tu mapu, prosím.
Bye-bye.
Okay.
It was a wonderful session. We will have lunch and we will renew it in
hour.
one
Yeah,
hour,
yeah.
right? Okay.